So yeah, let's talk about Taylor, Dave.
Let's do it. Yeah,
So,
maybe that's the best way, is to look at her testing.
yeah, let's do that. So
I really just want to get inside the mind behind the matrix.
okay. So here's what I got. So just for those in the know or not in the know, right shoulder pain, insidious onset. Reaching for things seems to be problematic, especially behind. Sleeping directly on it, holding a milk jug. And so I will share my screen with you because here's the testing. Boom. Okay, can you see that?
Yep.
Awesome. Okay, so here's what we got. We got, let's see, toe touch to squat. 5 out of 5 is full depth. This is a toe touch. 100%. Seated trunk rotation, 30 degrees. It's always left first, then right. So that's just how I notate from my standpoint, because I'm left-handed and lefties should be first in all things.
Wow.
Yeah. So we got 30 degrees, limited external rotation of the hip, narrow infrasternal angle, crazy straight leg raise, flexion, limited IR. That was painful. So I would say the ones that stood out to me were obviously this, that, like these are kind of my first markers that I'm looking at when I see Taylor.
Okay.
And then obviously, actually VIP should probably be this, because she doesn't care about the others, right? That's the goal. That's the money. We changed shoulder abduction. That was painful.
Mm-hmm. Yeah. Yeah. So why do those so when you're first looking at all this,
Mm-hmm.
are you kind of holistically taking all the relationships into account?
What do you mean by that? Can you tell me a little bit
So
more?
like, are you looking at it, quote unquote, algorithmically of like, okay, she's missing bilateral ER and has massive IR. That tells me something about her hips. Or is it just, you're not just looking at those 3 values that you noted isolation, right? You're looking at them as like the things you're looking to influence, but in connection to the other values. Or like, say you only did those 3 tests, could you make a treatment protocol based on that?
Yes, I could.
Okay.
Because those 3 tests, so let me reshare. So Dave, these 3 tests right here, these are the top tier for me. Actually, and the top tier is even just this one, because I can make some decisions off of that alone, the infrasternal angle. I would say like the ones that are most meaningful are this guy. It gives me an appreciation of the bucket angle action of the ribs. And then this guy right here, which just tells me essentially what position the kind of the sacrum and the innominates are in. So like this is like the infrasternal angle of the pelvis. And actually, I would say it's kind of a measure of the infrapubic angle to a degree.
Right.
So does that make sense?
Yeah.
Okay, and let me just kind of illustrate that as well. So let me just pull up an infrapubic angle.
And are you also looking at like important tests based on their story?
Yes. So let me talk about this first, and then I'll answer that question. So you can see my pointer, right? My mouse.
Yeah. Yeah.
Okay. So if I adduct, if there's a femur here, and I adduct it this way, the femoral or the femur is going to be closer to this right here, right? The ischium. If I abduct, this is further away. Can you see that?
Mm-hmm.
So if, let's say, this is narrow, So I have a narrow infrapubic angle, which would be right here, because here's your pubis below that.
Mm-hmm.
If this is narrow, then that means this part and this part would be closer together, correct?
Right.
So your outlets would be closed. So if these are closer together, then as I go to adduct, I have a limitation because of the outlet position.
Right.
So it's a proxy measure for this. That's the Obers.
Okay.
Does that make sense?
Gotcha. Yeah, I see. It's like a pelvic floor. It's like a proxy pelvic floor test.
100%. Now, in terms of your question regarding what's going on with her and her tests, it doesn't necessarily drive decision making for me. What it drives is building rapport and a relationship with the client, because I can change an infrasternal angle and I can change an Obers, but they don't care about that unless I'm you get jazzed up about that. What they care about is, do I hurt less, and can I snatch 160 kilos like Taylor Kim, which still blows my mind.
But you still had to do do you feel like you had to do all that other testing kind of as a just in case something weird jumped out?
That's a good question.
Does it give you actually a better picture of the person, of all the patterns, so to speak? Like you said earlier, like I've seen 50 of that person.
Mm-hmm.
I feel like you subconsciously put people into buckets based on your experience, right?
Mm-hmm.
I just can't do that yet.
No, I mean, I disagree, though. I think you do that from a fitness standpoint. You do that from a, functional medicine standpoint. You do that from a lot of standpoints.
Well, I definitely do it from a, never mind. Anyways, so, okay.
So,
like when we talk, it's just, yeah. So I think putting into like all these, you know what I mean, structural eval standpoint. So, okay. So what were you saying about taking all the other tests into consideration?
the other tests are meaningful after those marker tests are taken care of. So we have like tier 1. We have tier 1 are these yellows.
Mm-hmm.
Right? And actually it would probably be this yellow, and this yellow would be tier 1. Now I'm looking at the second things because, okay, let's say I clean out all the yellows and with one move, which we were pretty close to doing with Taylor. And then I go look at these other moves. So then maybe the ones in, let's say, green start to be a little bit more meaningful. And actually, I would probably put this as a yellow as well. Because with these two, you're essentially approximating kind of pump handle action of the ribs or what's going on with the sternum and thorax. And actually, you probably can put this there. But this, like these guys here, and maybe other things like this or the straight leg raise, and even hip abduction like the greens.
Second tier.
Yep. Because a lot of times if I address the yellows first, then the greens are taken care of. Okay.
So now talk me through so here's where I really want to get to. Mm-hmm. I want to be able to eval someone, assign an activity, an exercise that's going to optimize their variability, capacity, and power, right? That's the name of the game.
For sure.
And so, like, barring trial and error, right, of like, let's see your tests. Okay, let's try the sideline trunk lift, this thing, that thing, and see if it gets better or not, right? I really want to know just the thought process, right? And the one area I feel somewhat comfortable in is infrasternal angle upper body exercise selection, right?
Mm-hmm.
Narrow reach, wide overhead.
Okay. Do you know why? Tell me why that is.
Narrow, you want pecs and serratus to pull and widen. And then wide, you want external obliques to narrow.
And one thing I would say, and again, we're probably just, I don't know. I mean, we're probably just getting too nitty gritty with this. I probably misspoke on serratus being something that pulls the rib cage back after talking with Bill. That's Bill Hartman.
Yeah.
Check him out. Give him a shot. It's probably more, so if like this is the lower portion of my ribs, serratus kind of runs along this way on the outside. Okay.
Mm-hmm.
And so if I contract serratus, it's actually going to externally rotate the ribs, not necessarily pull them back, because the rib cage is rounded. Right? When we think of someone with like a narrow infrasternal angle, we say the ribs are relatively straightened, but they're not straight. Right? I need something that they're more relatively straight, that pulls in this way, that is below the sternum. That's where the internal obliques, or I'm sorry, the transversus abdominis comes into play. Because the transversus abdominis is, if this is the rib cage, the transversus abdominis, the fiber orientation is kind of front and back. And so it's going to pull this way, and you can kind of see that. Let's go back to the desktop. Let's look at transversus.
Yeah, so I feel pretty comfortable with.
Can you see that though? Like how this attaches on the inner aspects of the rib cage and then pulls it back, or would internally rotate the ribs?
Yeah. Okay. So there's the linea alba. Yeah. Okay, that's making sense.
Okay.
So that's contracting and then pulling.
Whereas serratus, if we look at this, so you have to consider that the orientation of this is more rounded along the rib cage, and so it's actually going to pull these guys outward. It's going to pull this rib cage closer to us, as opposed to pulling this back, because there's a rounded orientation to this.
I see, but it is still widening the rib cage.
Well, it would narrow the rib cage because I'm reducing the.
Well, it would widen the. It would narrow the anterior posterior view. Like if I'm looking at this skeleton right there, or like looking at him standing directly to the side of him, versus looking at him from the front.
Yeah. So a lateral view. Yep.
Yeah, a lateral view, it would make the rib cage narrower.
Yes. So the side to side dimension.
It would
narrower.
Yeah. By pulling the ribs in the frontal plane laterally outwards.
Correct.
Yeah, that makes sense. But rather than grabbing like fingers and pulling rib cage back.
Yeah, it pulls.
It's more like this rather than this.
Well, it's more this.
Oh, okay.
It's more.
Oh,
this.
okay. Got it.
It's that action.
But still widening a narrow angle.
No, it would narrow.
Oh.
Because watch what this is.
So
this right here is rib external rotation.
Yeah. Okay. So does that change your
treatment?
Yeah.
No, it doesn't. It was more thinking through what anatomically is occurring. I need something that it was me mistaking the action of the serratus. I need something that IRs the ribs, which would be transversus abdominis, whereas serratus is more of a rib external rotator, which is why doing something side-lying that's more frontal plane oriented is actually really good for someone with a wide infrasternal angle, because you recruit serratus when you do that reach. And so what does serratus do?
Yeah.
It takes something super wide and then does that in relation.
I got it. Okay. And so it's just not really, it's not getting picked up a lot on like a diamond lazy bear.
I mean, it probably is, but not as much as the pec.
Okay, got it.
But we're also talking about different locations. Like pec is going to influence here, right, where the sternum is, because it attaches to the sternum. Transversus abdominis is influencing there, this portion, so lower rib. So we're talking, 8 through 12.
Okay. Okay, cool. So still though, I feel comfortable with, as far as exercise selection, what to do, wide and narrow. Just kind of simplifying it a little bit. And then, but with her, what was so we see that she's narrow enough, and is kind of diamond bear the go-to for narrow?
Has been for me as of late.
Just because it's the most effective.
Yeah, it seems that you adduct someone a little bit more, you get a little bit better pec recruitment. You can drive internal rotation this way because you're IRing the humerus a little bit more. I mean, which again gets you more pecs. It just seems to be a really money move as of late, and I feel good about coaching it. That's the important thing too. It's like, I might be able to do diamond bear really well, but you might do better with something else.
Yeah, there's multiple ways to skin the cat.
Yeah, as long as you know what you need to get.
Yeah.
That's the key. And what you're trying to do to the rib cage, that's the key. I don't care what Dave, I don't care what you do.
Yeah.
As long as you get the
I don't care either.
Good. Just do what works. Do what helps you peeps.
And then the ball, squeezing the ball in, that was just because she needed adductors because of the infrapubic angle.
Yes.
Because of what you were, because you're almost treating those as the pecs of the pelvis.
100%. 100%. Now I wouldn't.
So that's really that over.
Go ahead.
Is that Ober's like? So you're not necessarily thinking about pelvic positioning as far as tipped forward and facing right, as much as the infrapubic angle first.
Yes. Well, now here's where it gets kind of tricky. And not that I think from an execution standpoint, from an execution standpoint, it kind of matters. But I don't think we can accurately say that you can have someone who has an anteriorly tipped pelvis because of the obers. Because I think you can have a positive obers in two different scenarios. Because guess what?
Let's go there.
We will. A wide infrasternal angle can have a positive obers or limited pure adduction, but so can a narrow. But the mechanics that happen at the spine and that happen at the pelvis are different. So let's go there. Okay, so what I'm going to do then is I'll just draw the spine in a terrible fashion. So we got, cervical spine has a degree of lordosis. You got thoracic spine, kyphosis. lordosis, and then the sacrum right there. There's a little bit of kyphosis there. So I'm fairly accurate, right?
Mm-hmm.
So we got, let's see, L, S, T, and cervical spine, right? Now, if in the wide well, actually, let's go with the narrow first, okay? In the narrow infrasternal angle, and I'm going to really, really exaggerate this, but the curves are relatively reduced, right? So it's kind of more like this. And the sacrum is relatively, that's so terrible, but the sacrum is a bit more counter-nutated. Okay? Now, if the sacrum is counter-nutated, based on the mechanics at the SI joint, the pelvis in this case.
I have a question.
Yes, sir.
Why is the sacrum so counter-nutated? Like when you look at the other curves, they're maybe just somewhat flattened, but then the sacrum curve.
It's a bad drawing, honestly. Like okay. It's probably.
So it's just.
Yeah. Let me.
Okay, so they're all just moderately flattened.
Yes.
Okay, somewhat flatter lumbar. Okay, got it.
Well, yeah, and that's even probably terrible. But we'll say that, gosh dang it, I wish I didn't do that to the whole thing. Okay.
So we got slightly flattened cervical, slightly flattened T-spine, down a little further, slightly flattened lumbar.
There.
Boom.
There. That's relatively counter-nutated.
Okay. So
right, or extended.
Yeah.
Okay. Now, if this is counter-nutated this way, okay, then the pelvis, if pelvis is red, is going to be relatively anteriorly tilted.
Yeah.
Got that?
Yeah.
Okay. Now, let's say here, on this case, we have a wide infrasternal angle. And let's say this is a bit wider. Let's say just a bit wider. Maybe let's say 100, 110. So the sacrum in this case is counter-nutated, or I'm sorry, is nutated. Then what direction is the pelvis going to be tilted?
Posterior.
Bam, right? So then you would reason to believe that the Ober's test in this case, or your adduction test, whatever you use, would be positive or negative?
Negative.
Correct. Okay. But I'm sure you've seen people with wide infrasternal angles who have positive Ober's.
Yes.
So why is that?
Something to do with the ischium?
No.
Something to do with the infrapubic angle? No. I don't know.
Okay. What happens if I Go ahead.
Tie-dye T-band? Just kidding.
Mentorship failed. Mentor. Has to do with the lumbar spine.
Okay.
So watch this. Okay. There's our spine. Courtesy of Pixabay.
Wow.
Okay. So we got the sacrum. You can see how that's relatively nutated. Now, Dave, watch what happens if I really want to exaggerate the lumbar curve. Ready? So I'm going to make this more lordotic.
Mm-hmm.
Okay. Boom. So now even though the pelvis would be right here and is posteriorly tilted, what direction is it facing?
It's facing, isn't it facing way up? Like, isn't it facing the...
Is it like super posterior?
Oh,
it doesn't move that much.
Oh, I see. Just it's got a anterior orientation.
Yes. So even though it's posteriorly tilted, it's
I see.
yeah, it's
Yeah,
facing
I
this
see.
way.
Right. It's
So
in
it
a
looks
slight posterior tilt in a massive and a superseding anterior orientation.
yes.
Okay.
And
It's
so
order. It's because of the order of magnitude.
mhm. And you could potentially approximate this by checking the adduction range of motion with the hip flex versus extended. Because if I flex the hip, this is going to reduce the lumbar curve to a degree. And you might have full adduction there. Whereas with the narrow, I'm sorry, go ahead.
Yeah. It's sort of like that on the back, when you're on the back and you just put one foot up and then you push into adduction.
Yeah. So that's why that is how that is. At least that's what we think right now, right? I mean, that's how I'm theoretically thinking about this.
What's the value in that test then?
In what test?
In
the flex?
Flex adduction.
It's just another way to measure adduction. Like the tests are irrelevant. You just need to know what you're trying to look at. So find something that you can reproduce consistently that tells you the information you need to make an outcome or make a decision.
Okay, perfect. So on Taylor's second move, let's talk about your decision process to get there.
Okay. So we chose
I feel like I have a pretty good understanding of where her initial move came from. Positive overs. We need to we need to widen the infrapubic angle.
Yes, and I made that assumption secondary to the narrow infrasternal angle.
Yeah. And that just gave us the ball squeeze.
Yes. Because I can use the adductors to pry that open.
Okay.
So the second move was the pec twist.
Yeah, I had no idea what was going on there as far as let's talk about that one. How'd you arrive there?
So similar to the Diamond Bear, we're still going after pecs. It's more of a unilateral bias. But what you have to ask is, when I'm trying to make a narrow relatively wider, what do I have to do to the rib cage?
You have to take these guys and pry them in. You like this?
Yes. That's exactly why I did it. So you figure the Diamond Bear was to narrow the anterior posterior dimension. So I'm shaping the rib cage if like you're looking bottom up. Pecs did this.
Yeah.
Then I'm using the pec twist to maintain this sternal position. And then I'm using rotation to try to drive the rib internal rotation on either side to shape this portion a little bit more, theoretically.
Wow. So with her, it's all about ribcage shaping.
That's all it is with everyone. If you talk to me today, right now, like that's what my thought process is the whole time, is to know what I
was going to ask you earlier before our little problem
distraction
came up was about, like, what does your movement menu look like these days in terms of quantity of exercises? I mean, how many would you say you choose from? I realize that you're making them based on the person, but if you had to take a guess, would you say 10, 20, 50, 100 different moves? What kind of permutation are you using?
You're talking just variability, right?
Yes. Just first two sessions to restore variability. Yes.
Okay.
Not addressing active mid stance annex if that's what you consider capacity and power.
Yeah. I mean, I've still put that in the variability camp.
Okay.
I would say like maybe I have 5 for a wide, 5 for a narrow. And then if I'm restoring, like trying to restore more pump handle, or I'm doing things up here, it's probably 3 to 5. So maybe 20, if that. But or what it is it's just like I have these couple staples, and then I'm just changing what the extremities are doing around the staples. For example, like if I have someone who I had someone who I eval'd recently who we were trying to drive hip external rotation, but we didn't always clear up this, but other things were cleared. And so I gave him something, instead of squeezing the ball, we had him push a band out slightly to get the external rotation back. And it worked.
You mean the dorsal breathing with glute emphasis?
Yes. Yeah, exactly. That one, and then the straight leg raise crossovers with glute emphasis, or glute bias, I think I call it. That was it. So it's just like I'm still, with those two, I'm still thinking same thing, rib cage, right? This person was narrow who I gave that to. So I'm doing something to get pecs to ding this in and then lift up, so I get a little bit of pump handle activity from the pec. And then with the other one, I'm driving rotation to drive the rib internal rotation. And it's just changing a little bit what's going on with the extremities, because we had already restored adduction in IR. Now we had to get an abduction in ER.
Got it. So, that second pec twist, we went with that just because she was just a classic narrow.
That, and to restore internal rotation of the shoulder too, because the shoulder is the measures of the shoulder are measuring what's happening up here. And so what I'm thinking about is, okay, can this person pump handle or not? If you think about respiratory mechanics, in the narrow case, I have decreased pump handle activity regardless of what it looks like, because it's more of a relatively exhaled position. So if I don't have as much pump handle, typically that's associated with more of an IR loss.
Yeah.
If I can't pump handle. So what did I do? What can help me get a pump handle? Well, a pec can, because it's going to pull up, right, from the sternum. So it allows this to happen. That's why I went with that, just to clean up that last little bit of IR.
Wow. Okay. Perfect. And then just the lower body, having her keep those knees together was just preventing lumbar rotation. So she's getting true thoracic rotation.
There was that, but then also because I was having her do the hard squeeze, we're still driving the adductor. So it's the same thing, but I'm just challenging the plane that she's working in. Now, when I did the shift and I coached that, or I did coach that with her, didn't I? Or did I just say squeeze?
Mm-hmm.
Yeah.
Yeah, you shifted.
Yeah, the shift is going to bias the rotation a little bit more, but we're still getting adductors. We're still doing all these things, but maybe making it a little bit more of a unilateral emphasis.
Okay. Can we look at her measures one more time?
One more time, yes. And then I have to go, my friend.
Okay. Got a hot date.
Hot date with one patient. So, yeah, here's where we start.
Don't allow her to fall in love. I remember we've addressed that. Okay, so her massive IR and straight leg raise, that's not bothering you because it's not bothering her. Is that right?
It's just not like, it's not a decision maker, deal breaker for me right now, because it's not as important as this and this.
Okay.
Now, could it be a problem at some point? Maybe. I don't know. Maybe she can control and coordinate it.
Okay. I got it.
Like,
you need to go to work.
I do. Like, let's say we did those 2 moves and we tested active mid stance and like a Copenhagen adductor. And
Right.
she's Gucci. You keep your 120 degree straight leg raise.
Wow.
Yeah. Because if you can control it, man, then you're cool.
I like that. All right, homeboy. Have a good day.
You too, man. I'll send this to you when we're done. And I've edited it.
Yeah, edit it and put it on YouTube.
I will, man. I'll send it your way. Thanks for your time. We should do this again sometime.
Yeah, let's do it all the time. I love you. Bye.
Love you too. Bye.